Welcome everybody to Parkinson Place and our Ask the Doctor series. Thank you, Dr. Ramos, for being here. Today he's going to be talking about the complications of levodopa treatment. We're asking everyone to remain muted. Any questions, please type them in the chat box. And if there's time, Doctor will answer them. Okay, thank you.
Well, good afternoon, everyone. So this is actually a topic that takes a lot of our time in everyday practice. It's a simple matter to begin treatment with dopamine replacement for the primary symptoms of Parkinson's disease. Most primary care doctors can do that. Ever since the discovery that there was a dopamine deficiency in the deep part of the brain known as the nigrostriatal system. Once that was discovered, it became very clear that you could replace dopamine, at least for a while, by giving the natural precursor to dopamine, and that's what levodopa is. It's one of 20 amino acids that are found in all proteins. Proteins are made up of building blocks called amino acids, and one of them is known as levodopa, which is part of other proteins, but levodopa, as well as other amino acids, can be used as the raw material for making neurotransmitters. For example, levodopa, when it's taken up into the brain and into neurons, dopamine-producing neurons, convert the levodopa into dopamine and stores it in little vesicles, little packets at the nerve endings, ready to be released to send the message to the adjacent neuron that it connects with. Similarly, serotonin, 5-hydroxytryptamine, is made from tryptophan, which is another amino acid. And serotonin is also diminished in Parkinson's disease, and it's associated with depression and issues with sleep. In fact, when there's a deficiency of dopamine, we're all very aware that there are going to be the problems of slowness of movement, difficulty initiating movement, as well as rest tremor. With time, there's also a loss of balance, but that's not so related to dopamine loss. It's still a bit of an issue as to why people begin to lose their balance, even though you can replace their dopamine. The other features, besides the diminishment of serotonin that results in depression and lack of motivation and issues with sleep-wake cycles, is the lack of norepinephrine, which is further downstream from dopamine. And it's a neurotransmitter that's very important in mediating the autonomic nervous system excitatory components. For example, we all know what adrenaline is. That's produced by the glands that sit on top of the kidneys. When there's a stress or a sudden shock, adrenaline is released into the circulation, and it acts on heart and brain and skin to get you ready to fight or flight. So it's the fear response results in adrenaline being released, and you can run forever, you can fight, you can protect yourself. And if you don't run and you're just frozen in fear, you shake like mad. That's noradrenaline. So in Parkinson's disease, there's a deficiency of noradrenaline production as well. And that results in issues of lightheadedness when you go to stand up, sometimes feelings of hot and cold, having to do with the noradrenaline acting on the skin receptors that kind of open and close the pores, and pilar erection. So norepinephrine causes your hair to stand on end, and adrenaline too. So noradrenaline or norepinephrine is the same thing because it's very similar, just one step beyond adrenaline. So that's just some of the basic issues. But what we discovered after the introduction of levodopa, which is a remarkable drug for alleviating slowness, rigidity, is that soon after it was introduced in the 60s, and of course it was a revolution in the treatment of Parkinson's disease. Before then, we had to use belladonna alkaloids or cannabis preparations, or really nothing but physical therapy. From the 60s, we used levodopa, and we realized that to get the most out of levodopa, you should pair it with carbidopa, because levodopa, when you take it in the diet or in a pill, it's metabolized in the blood and liver into dopamine. And dopamine cannot penetrate from blood to brain. And so it's metabolized further and eliminated. So you have to give maybe 8 grams of levodopa if you give it without carbidopa in order to get enough levodopa into the brain. But adding carbidopa protects the breakdown of levodopa outside of the brain and allowing levodopa to get into the brain through a special transporter called the neutral amino acid transporter, where then it can be converted into dopamine and stored for release. So that was the big breakthrough. The combination of carbidopa with levodopa allowed you to take levodopa in milligram amounts, but levodopa all by itself, you need to take grams, 1,000-fold higher. Remember, 1 gram is 1,000 milligrams, and people usually take 100 milligrams in a tablet or 250 milligrams in a tablet, as opposed to 8 grams of levodopa in the old days. And of course, you can imagine in the old days, when they first started with levodopa, most people couldn't tolerate it. They get nauseous and vomit and so forth. That's why the brand name carbidopa levodopa was known as the no vomit levodopa. And no vomit in Latin is sin emesis. And there you can see how the advertisers and branders called it Sinemet, meaning levodopa without nausea and vomiting. So hopefully when I talk about Sinemet, you'll always remember that origin of that name related to the fact that levodopa, when it's given with carbidopa, is patentable. It was a patent. It's no longer on patent. It expired. And there's generic carbidopa levodopa. So that's not what I'm going to talk about. That's just the background to try to shed some, kind of give you a perspective on what happens now when we replace dopamine with levodopa. So I'm going to go back to my notes. So though many patients improve pretty dramatically in terms of their slowness, it improves, they become more normally movement. The tremor may or may not get better. Some patients still have a little rest tremor, but rest tremor really doesn't interfere with motor function, because as soon as you move the hand, the tremor will stop, unless it's an essential tremor, which is treated differently. But they noted that between 5 and 10 years after treatment with levodopa carbidopa, about half the patients would develop these abnormal movements, what we call motor complications, that weren't present before levodopa was given. In other words, the dyskinesias, or abnormal involuntary movements, are drug-induced in a patient with Parkinson's disease. That typically you don't see some of these movements at all. You might see some dystonia, and we'll talk about that, abnormal posturing, as part of the essence of the disease, untreated disease. In fact, many people who are experts in Parkinson's disease consider Parkinson's disease as being a slowly progressive, generalized dystonia. And by dystonia, we mean abnormal posture of a limb, of the trunk, that is related to sustained contraction of muscles without being counterbalanced by the antagonist muscles. In Parkinson's, you can see that the arms flex, so the arms are flexed and more stiff. The body flexes forward in a stooped posture. Those are dystonic postures that are typical of PD. And in the old days, before levodopa, that generalized dystonia would progress so much that people would be kind of bent at the waist with their head looking down, and their steps would look inch by inch, and their arms were flexed up at their chest like this, almost like going back to a fetal position. That's what the dystonia is all about in terms of the basis of the illness. The levodopa would prevent that. And so people on levodopa would never develop this generalized postural dystonia. They might get a little bit of it because the levodopa doesn't stop progression, but it allows you to function so much better for many years. But as I say, between 5 and 10 years of treatment with this miracle drug results in about half the patients developing these motor complications. Some studies that have reported as many as 80% of people taking levodopa carbidopa will develop, quote, motor fluctuations, end quote. So what are the factors that increase the chances? Not everyone gets these. Maybe 20 to 50% of people never get these kinds of complex motor fluctuations I'm going to describe. So one is how long you've had the disease and how severe the disease is and the amount of time you've been treated. All those factors play a role. So, and also if you take more than 600 milligrams per day, you're more of levodopa. you're more likely to develop motor complications. Doesn't mean you will definitely get it, but these are increasing likelihood. If you develop the age of onset before the age of 50, like in the 40s or 30s, which is less common, those individuals develop motor complications really quickly and severely. And by that, I should describe what I mean by motor complications. There are two major types. One is just a motor fluctuation where you are on and off and transitioning between on and off. And that's related to, let me describe what on is. I say on, everyone knows how to turn on the light, and suddenly the lights come on and you know how to turn it off. But on just means a gradual reduction in the motor symptoms when you start treatment with levodopa. There's a gradual disappearance of the motor features of PD. And off is a gradual process too, in general, gradual wearing off, because there can be a sudden off, we'll talk about that. And then if it's sudden off that lasts for seconds, it's called freezing. But off generally refers to a gradual wearing off of the benefit of the medication, or another way to look at it, reemergence of the symptoms of Parkinson's. So you start seeing the tremor again, you start seeing slowness and rigidity until you take the drug again, and then you repeat it, maybe 4 to 6 hours later, and the symptoms gradually wear off. In other words, you come on, and then you're on for X amount of time, and you wear off. Now, in the beginning of the illness, when you begin to treat with levodopa, oftentimes one just needs one tablet of 25-100. In other words, 100 milligrams of levodopa taken maybe 6 hours apart or with each meal. And the effect lasts all day without fluctuations. People are on the whole day. But with time, that on period gets shorter and shorter. And that really relates to the fact that there's less capacity to store dopamine in the neurons, because as the illness advances, those neurons that make and store dopamine, the nigral neurons that project to the striatum, there's less and less of them, so there's less and less capacity to store dopamine in those terminals. So when you take 100 milligrams of levodopa, you make it, it's stored, but you can't store much of it, so you start seeing the off period come on a lot sooner. Okay, later in the illness, of course, it can get really, really short. So someone may need to take the medicine every 3 hours because it doesn't last. Even a 25-50 dose, 250 milligrams of levodopa, in some people who've had it for the illness for some time, need to repeat that dosage 3 or 4 times every 3 hours. So they end up taking it 5 times a day during the waking hours. And I'm going to be talking about how to address these issues at the end. How do we treat the shortening on period? How do we treat this kinesias? That's the last part of this talk. I'm not going to bring it up now. So the other part, besides the on and off, the wearing off, and the quick wearing off, we call that usually something comes on many years later. And typically people have gone through the gradual wearing off phenomenon. And then eventually, even though the medicine is working, they can suddenly come off. It's like going through a doorway or being in a narrow space. They suddenly become immobile. And then if it's a freezing episode, it can be broken pretty quickly and they can initiate their gait again. So that's the most troubling part of the wearing off. There is a sudden off or freezing episode. Those are the most dangerous because they're kind of unpredictable. And so if your feet suddenly become stuck to the ground, the momentum can cause you to go forward and fall. Okay. So dyskinesias are the second part of motor fluctuations. And that just means, kinesia just means movement, like kinetic describes movements. Hyperkinetic means excessive movement. Hypokinetic means less movement. PD is known as a hypokinetic disorder, whereas Huntington's disease is known as a hyperkinetic disorder because they have excessive movements, constantly moving, dancing movements. So dyskinesia is an abnormal kind of movement. A not normal, dysfunctional, so to speak. These abnormal movements are multiple types. They can be involuntary twisting and turning motions of the arms, legs, head, and trunk. They can involve grimacing of the face, clamping of the jaw, moving of the jaw, etc. These patterns of twisting and turning movements really vary from individual to individual. They typically are more, when they first appear, they're more on the side in which the symptoms began. So if one began with a tremor and decreased handwriting size on the right hand, when the dyskinesias do appear, if they appear, they'll involve, first of all, the right side. Eventually, both sides will be dyskinetic. And as the illness advances, the dyskinesia can involve the entire body. There are certain patterns of dyskinesia that I always request my patients who do have on and off, sudden off, and dyskinesia to note when these things happen in relationship to the timing of the medication, to keep a diary. So when they develop a dance-like dyskinetic movement, they should write it at the time they first noticed it, write down the hour, and when they took the drug and when the next time to take the drug is. So you have it on a time scale in a journal. The reason is that the different patterns of dyskinesia will be treated somewhat differently. So there's something called peak dose dyskinesia, which occurs when the level of dopamine is at its highest level in the brain. And so as the drug is kicking in, you're starting to come on, and just as the drug is almost completely on, you have all these excessive movements, and that can be just for a short period, could be 5 or 10 minutes, or 20 or 30 minutes, and then those dyskinesias disappear and you're on, like normal. And then you wear off again, but if you're lucky, if you take the medicine on the right schedule, you won't wear off. But if you do have peak dose dyskinesia, you might have another period where you have an hour, 45 minutes after taking the medicine, you have the dyskinesia lasts for a time, then you're on. So that's one pattern called peak dose dyskinesia, where the dyskinesia comes within an hour of taking the medication. The wearing off dyskinesia occurs just as maybe a half hour, 45 minutes before the next dose is due. So if you took the drug at 9, the next dose is due at 1 o'clock. By 12 or 12:30, you start seeing what look like peak dose dyskinesias, but it's called an off dose dyskinesia. So the way to look at it, as the dopamine interacts with the receptors that are very sensitive, you get peak dose dyskinesia. And as the dopamine is coming off of those receptors, because you don't have enough dopamine in the striatum anymore, you end up having the dyskinesias. Most people will have the biphasic dyskinesia, where they have both on and off, wearing off dyskinesias. And then there are individuals, if they wait a bit too long before the next dose, have what is called an off-period dystonia. Can often be a turning in of the foot, a cramping of the foot or the arm. And it almost looks like a very focal dystonia. It is a focal dystonia that occurs as the drug is wearing off. So I'll summarize that again. And typically the diphasic dyskinesias, that means there are two phases to the appearance of those dyskinesias. What's interesting is that one of the authors that I reviewed, and I tend to agree, that the diphasic dyskinesia tend to involve the legs more and consist of slow and repetitive, slow dystonic movements in the legs. The wearing off part of it is in the legs more. So the off-period dystonia can be, any part of the body, but most commonly it's a hand, a foot, or a leg. But in some people, they have a generalized whole body dystonia, they just become very stiff and can't move. And it looks just like the reemergence of Parkinson's, which is a general dystonic disorder. One also has this phenomenon called early morning dystonia, which when they've had the illness for many years, these things don't happen in the beginning stages of the illness. They'll wake up complete with dystonia and the cramp and a cramping tightness of the foot or the arm. And then when they take the Cinnamate, that gradually goes away within a half hour to 45 minutes, depending on how much protein they have in their breakfast or in their belly or being digested. So understanding how these motor complications appear is incompletely, really. It's being explored. There's some aspects of wearing off that we do understand, and I'll go over them. And then some aspects are incompletely understood. So one of the important reasons, and I alluded to it already, for wearing off is there's not enough dopamine storage in the brain. So one starts wearing off. As the illness advances, you have less capacity to store dopamine, so the on period is shorter and shorter over the years. You have to make adjustments to the medications and to the schedule. So one of the explanations for the wearing off for many of these complications, I'm just pretty general, are called pharmacokinetic, the movement of the drug in the body from the time you take it in the gut, gets into the blood, transported to brain, stored in neurons. Any of the changes in absorption, transportation to and across the brain of levodopa has been, implicated in the development of these movement disorders. So the amount of levodopa produced in the brain, if it's reduced, can result in an off state. Erratic levels of levodopa delivered to the brain could result in development of dyskinesias. In fact, it's one of the big explanations for why regular levodopa, which has a quick onset and quick offset, it's more of a pulsatile, it turns you on and turns you off, or more likely to cause dyskinesias. Whereas if you had tonic stimulation, constant, steady stimulation of dopamine receptors, because you have nice, steady storage and release of dopamine, will result in normal motor function without dyskinesias. In fact, that already hinted at how we try to treat dyskinesias, is by using dopamine drugs that are constantly delivered and act at a steady level on dopamine receptors. Some of it, however, there are some individuals that have really bad levodopa-induced dyskinesias where there are no difference, and compared to others without it, there's not much difference in the pharmacokinetics in some of these people. So just alterations in the levodopa pathway, its metabolism and storage, may not account for some of these, especially the dyskinesia component. It can account for the gradual wearing off and the gradual kicking on of the drug, the pharmacokinetics. But why we have dyskinesias is something a little trickier, and I'll get to it. I have another section I wrote here to underscore the importance of the storage hypothesis, quote unquote. So as the illness advances, there's reduced capacity to store levodopa in the dopamine-producing nerve terminals that project to the striatum. It leaves no buffering capacity after levodopa. So when you give levodopa, it's quickly transported into brain pretty quickly, and there it's made the dopamine, but the rest of it circulating in the blood is metabolized and eliminated from the body, so that one will need to give higher doses of levodopa to have more of it circulating in the blood to compensate for the diminished buffering capacity. So that's the approach that we use for a gradual wearing off. We just increase the dosage. Many of you have gone through that. We might start off with 25-100, 3 times a day, then we'll go to 4 times a day, then we go to 25-250, 4 times a day, etc. By just constantly elevating the amount of levodopa that can circulate in the blood and get into the brain. So that's the buffering hypothesis. And there's really, the evidence is growing that, and I'll give you some of that the pulsatile administration of levodopa to the brain, and I was using quick onset and quick offset levodopa, which is wonderful if you're really unhappy being stuck and you take the medicine and it kicks in quickly. that's great. But if you do that a lot and use just regular immediate access 25, 100 levodopa, that leads to changes in the dopamine receptors that make them, that dysregulate the feedback system. And what happens is if you use pulsatile levodopa, regular levodopa, in a young onset patient, and you keep on increasing the dose because they keep on wearing off shorter and shorter periods of time, and you just increase the total amount of levodopa, they end up having an excessive reaction to dopamine. So it's the dopamine receptors become what we call super sensitive, where a dose of X normally would produce a normal response. That same dose after a certain amount of time will produce an excessive response. That means that the receptors are super sensitive. They overreact to dopamine. And that's the essence of what's happening to the dopamine nigrostriatal system in the development of dyskinesias. In animal models, from the 19th century, we had a notion of denervation, a proof, a concept that's based on experiments. And I really remember this experiment because it was in basic physiology, neurophysiology in college. And it looked at denervation supersensitivity of a nerve muscle preparation. In the 19th century, they often took the muscle, the hind leg of a frog, put it in a physiological medium, and dissected out the nerve that stimulated the muscle to contract. And they were able to stimulate electrically the nerve, and the muscle would contract, and they measured the strength of contraction. And if you stimulate very frequently, the neurotransmitter is depleted, and after a while, the muscle doesn't contract. So you lose the sensitivity of the muscle. In this case, it's not dopamine, it's called acetylcholine, because that's a neurotransmitter that communicates from motor neurons to muscle to contract. And what was interesting is that the guy who developed this assay was able to take the medium, and that medium put into another set of nerve muscles would cause the muscle contract. That's how they learned that electrical stimulation to the muscle involves a chemical mediator or messenger. That was the beginning of our concepts of neurotransmission using molecular mediators of one nerve talking to another. Is not just electrical, but across the synapse, the gap between the nerve ending and the nerve receptor involves release of chemicals. So what happened in a muscle preparation, nerve muscle preparation of the frog, where they crushed the nerve and the nerve starts degenerating. What they notice is that the muscle spontaneously starts contracting without any nerve stimulation. As you denervate, the acetylcholine receptors expand in number and in sensitivity, so they spontaneously contract. Similar thing happens in ALS. In ALS, the motor neurons are degenerating. So the muscles don't get that acetylcholine stimulation, so they start fasciculating, contracting spontaneously. And that is what we learned in medical school. It's the motor neuron waving goodbye, because as the neurons are dying, the receptors become oversensitive, receptors in the muscle in the case of ALS. And so they become oversensitive and they spontaneously contract. A very similar phenomenon is occurring in the nigrostriatal system, where you're losing dopamine neurons. The receptors in the striatum, the neurons that respond to dopamine, they expand in number and sensitivity. So then they spontaneously can send on the message downstream. Or if you give a relatively low dose of dopamine, it'll overreact and cause a dyskinesia. So that's, in an essence, the way we like to look at dyskinesias as evidence of the supersensitivity of dopaminergic receptors. So, and it's a dysregulation of how the striatum sends messages to the rest of the brain. And that's one of the problems that we have to face in this disorder. And now I'm going to talk a bit about how to deal with this. So because of the idea that it's this pulsatile administration of levodopa that tends to aggravate the dyskinesias and cause the dyskinesias, we like to have medications that act longer and more steadily and aren't so quickly metabolized. So That was the reason and the rationale for developing controlled release Cinemat or extended release Cinemat. And usually it's in a matrix that allows the levodopa to be released into the blood a lot slower. Unfortunately, they found that even when you start treating with controlled release levodopa, it's even, say young patients who are already at risk for dyskinesias, they'll develop the dyskinesias, whether you use regular onset levodopa or controlled release levodopa. However, controlled release levodopa, the long-acting levodopa, and there's several more that are available now. Rytari, for example, is a new brand that contains regular release as well as slowly released. And that combination is what's being used more and more, but since it's a new drug, it can be expensive, and many insurance companies don't like to underwrite it. Certainly long-acting Cinemat is not a bad idea to use at bedtime for individuals who wake up early in the morning with end-of-dose dystonia. Sometimes you can diminish that dystonia in the early morning. And certainly the problem with controlled release Cinemat is that it can accumulate levodopa in the systemic circulation. And then they can end up with excessive dopamine in the brain and cause problems in that way. One of the solutions I had used was a solution called liquid Cinemat, where you prepare it in water, say 10 tablets of 2500, a gram of levodopa and a liter of water, add vitamin C to prevent it from being oxidized. If you ever put levodopa, carbidopa in water, you'll see it gradually turns brown because it forms a polymer, which is brown. But if you have ascorbic acid in the medium, it protects it. So individuals can take maybe 100 cc's to get the day started, and every 2 hours take a sip of liquid Cinemat. I've done that for people who have almost an OCD aspect about taking their medicine. They have a cooler, a thermos that keeps it cool. You prepare just the amount of levodopa in liquid that you need for the day, because you can't keep it more than a day, and you keep it refrigerated and light-free, so you have an opaque container. And that's one of the ways that I used to do it, especially for young onset people who had really bad motor fluctuations. And by them taking small amounts throughout the day, they could have tonic stimulation of dopamine receptors and not wear off, not have too many dyskinesias. So that was called the liquid or Cinemat. I told you what the obstacles are. It requires very frequent dosing, typically every 2 hours. And it's a solution that's got to be prepared every day, fresh. The other approach is to add a dopamine agonist. Now, that's the whole reason that people began to develop dopamine agonists, because they could develop a dopamine agonist does not have to be metabolized into dopamine. It acts like dopamine. To the dopamine receptor, the dopamine agonist looks like dopamine, though structurally it's a bit different, but it fits it like a key into the lock of the dopamine receptor and sends the message to the striatal neuron. So it works just like dopamine. The beauty of it is that it penetrates the blood-brain barrier without concern with what you've eaten, whereas levodopa can be impeded in its transport from blood to brain simply by having too much other protein digestion going on, because other amino acids that are being produced in the blood during digestion compete with levodopa for entry into the brain. So it can, by adding a dopamine agonist to regular levodopa, you can smooth out the response. And so people have less motor fluctuations. Another approach that's been out there and even led to a new patent is called Stalevo, where by adding an enzyme inhibitor called entacapone, it inhibits one of the enzymes called COMT that breaks down levodopa in the blood. It allows levodopa to circulate longer in the blood. And so the duration of on time is a bit longer if you have entacapone, levodopa plus carbidopa, which is available in one capsule as a drug called Stalevo. Or alternatively, one can use entacapone, 200 milligrams 4 times a day, separately from the levodopa carbidopa. So we do that a lot. And it's really very good for when people are wearing off after 3 hours. You want to give them an extra period of on time it's good like 4 hours of on time, then it's good to add entacapone. Let's see what else here. So one of the important approaches that I used to have a lot of fairly young Parkinson patients when I was at the University of Miami, and many of them had really severe dyskinesias. And the only way you could really get rid of them is to gradually lower the levodopa, lower and lower as you increase the dopamine agonist. And one of the ones I was using then was pergolide. And I'm not going to give you the reasoning behind it, but it acts more on a D1 receptor than other dopamine agonists. And we had hypothesis that if you activate the subtype of dopamine receptor that pergolide does, you can perhaps diminish the amount of dyskinesias, the excessive involuntary movements. And you could only accomplish that by lowering the amount of levodopa, because if someone already has dyskinesias triggered by levodopa, and then you add an agonist, those dyskinesias will be amplified. So whenever you want to use a dopamine agonist like pergolide, or pramipexole is the one that's more popular now, called Mirapex. If you just add that on to a person that has dyskinesias, they're going to have worse dyskinesias. So you have to lower the amount of levodopa as you increase the pramipexole or Requip or the pergolide, known as Permax. It's a tricky business, and I actually wrote a paper years ago where I used pergolide monotherapy for a young patient with very severe motor fluctuations and dyskinesias. The only way I could get him without dyskinesias at all was have him completely off Sinemet and treat him with much higher doses than are recommended of pergolide. The problem with high doses of pergolide, it worked great. They were functioning motorically well, but pergolide, as well as Mirapex at higher doses, has a lot of psychiatric side effects and physiological. They both can cause lightheadedness on standing, like too high a dose of levodopa. They can cause kind of obsessive compulsive gambling, obsessions about sexuality, sometimes paraphilias. So that has limited the use of high dose monotherapy with dopamine agonists. Finally, the dopamine agonist that I use a lot that results in various tonics release of dopamine is called rotigotine, which is the only drug available as a patch called Nupro. And it comes as 2, 4, 6, and 8 milligrams daily. It's 1 patch per day. So this one doesn't cause all of this compulsive problem. It's very rare that it does. But that's one of the ways I deal with people that have complex motor fluctuations. So I'll get the patch, start with a low dose, and gradually lower the Sinemet as I increase the dosage of the Nupro patch. And then the final, well, there's another new class of drugs I know that are available that are, I don't know if it's, I have not used it, but they're called adenosine antagonists. And it's a lot like related to the caffeine type drugs. It's called istradelaphine. And it does help with motor fluctuations. And I think, for example, in one of the studies I have here, patients with motor fluctuation, they found a significant reduction in percentage of daily awake off time, a small increase in on time without dyskinesia, and there was significant increase in on time with dyskinesia. So it's not perfect. So I tend not to use that other drug called the adenosine antagonist. And finally, the best treatment that takes commitment, though, is the deep brain stimulation. That is now the gold standard for achieving a smooth response to levodopa, allowing one to markedly diminish the amount of levodopa one takes. You can tune it by adjusting frequency and voltage with a remote control. Of course, you have to be trained to do that, and they'll have technicians do it for the first 6 months to a year. And that allows you to turn down the dyskinesias, turn on the ability to walk and so forth. That was a wrong choice. Not the ability to walk, the ability to move more normally, to use your hands normally, to have fine manipulations, to get rid of tremor. So in fact, deep brain stimulation is probably much better for tremor relief than any medication. In fact, deep brain stimulation was first used to treat really severe action tremors, but that targeted the thalamus, whereas the subthalamic nucleus that is targeted in PD will alleviate dyskinesias, improve on time, and eliminate tremor. What it doesn't really help with is the loss of balance. In fact, none of the drugs I've talked about, including levodopa, dopamine agonists, deep brain stimulation, will guarantee against falls. Once one begins to fall, that's stage 3, or has a tendency to fall. Stage 4 is when you fall a lot and you need a walker or a wheelchair. Deep brain stimulation should not be considered as something to treat balance problems. And so that's important to know. When you have a consultation with a neurosurgeon, they go over that. The other things is that if you have cognitive issues, pretty significant cognitive issues, and many people with Parkinson's disease do have cognitive decline, you really should not have an electrode put in to the deep subthalamic nucleus, because it can worsen cognitive changes. But that's why when the third thing about deep brain stimulation is that you have to be responsive to levodopa. If you use it to deal with slowness, rigidity, and tremor in a person that has atypical Parkinsonism, in other words, not Parkinsonism that doesn't get better with dopamine replacement, then you won't get any better with deep brain stimulation. So when you're seen by a neurosurgeon to be considered for deep brain stimulation, there are two things they do. You come into their clinic early in the morning without having taken any medicine since the night before, since you went to bed. So you're in an off period when they see you. They do an exam on a standardized rating scale, the Unified PD rating scale. You get a score. Then they give you a test dose of levodopa carbidopa that typically turns you on. And then they measure your motor rating again. And if you get an improvement of 30% on that motor score, that means you are responsive to dopamine replacement. It means you're a candidate for deep brain stimulation. If you don't have a positive response to dopamine replacement, you won't be considered for deep brain stimulation. You have a variant of this rigid akinetic syndrome that's going to be difficult to treat. Luckily, those aren't that common. The bulk of Parkinson's syndromes respond to dopamine replacement. And finally, you have to have a battery of cognitive assessments. And if you score below a certain threshold, they'd recommend against having deep brain stimulation. And they usually do it in staged procedures. They'll usually, if your right side is has the worst dystonia, dyskinesia, they'll put the stimulant on the deep brain stimulator on the left side. And then eventually they can go on and do the other side. Some people can do very well with just one electrode. They may not need bilateral. Depends on each individual. Let's see. So let me summarize. It's not difficult to make a diagnosis of Parkinson's syndrome, and one can confirm it's Parkinson's disease by the alleviation of slowness of movement, cogwheel rigidity, plus or minus relief of tremor. You eliminate a lot of the atypical Parkinson's syndromes by noting that they don't get any better with dopamine replacement. Number 2 is once individuals are diagnosed with Parkinson's disease and you work up a schedule, the age at which they develop the illness is very important. If they develop the illness before the age of 60 and they need dopamine replacement in order to keep working or to keep functioning normally, then we don't use levodopa carbidopa. We'll use a dopamine agonist. And so the dopamine agonist will be used, and after a while, as the illness advances, we can then add levodopa carbidopa. If one is over 60 at the age of diagnosis and needs relief of their symptoms of slowness and rigidity in order to function better, then we'll start with levodopa carbidopa in those people. So I think that's the other thing is, just because you see that there's slowness of movement, change in handwriting, some mild difficulty in dexterity, some mild rigidity, doesn't mean you should immediately start treating with dopamine replacement. In fact, if the symptoms are there, but don't interfere with ability to work, to use the keyboard to any great degree, to do everyday activities, then it's better to delay using either the dopamine agonist or Sinemet, but instead use something like selegiline or rasagiline. So those are agents that may delay the need for levodopa. And then if the symptoms are very mild, but aren't that severe, then we'll often use amantadine before starting levodopa or dopamine agonists. So my usual route is if a person's young, they don't need medication yet because they're still functioning pretty well, but it's clear they've got mild cognitive rigidity, mild decreased dexterity. You can see that their handwriting is getting smaller. I'll use amantadine and selegiline first. And then if their symptoms continue to progress and they're starting to have problem with everyday activities, then I'll put a young person, less than 60, on levodopa carbidopa. I'm sorry, dopamine agonists. If they're over 60 and need symptomatic relief, I'll put them immediately on levodopa carbidopa. And that's all. I'll be glad to answer questions on this topic. Can you comment on the use of Inbrija when you're regularly using carbidopa, levodopa? The problem with Inbrija, it's the same problem I have with apomorphine. It's for people who are suddenly off, but aren't coming on, and it's emergency use. So apomorphine is a dopamine agonist, and you inject it, and you can come on very quickly. It's just a problem to have to inject yourself, but some people like it. I personally never use it. Also makes you nauseous. You have to take an antiemetic. The other is Inbrija is levodopa carbidopa, quick onset. It's a rescue. What I don't like about it is it's going to increase the probability of developing dyskinesia. So I never, ever recommend inhaled levodopa carbidopa. So that's one. Can you comment on the use of, I recently watched a 10-year-old Michael J. Fox interview where he adjusts his medication dose based on how he feels at the time. No, that's not a good idea. It's really good to work with the neurologist to work out a schedule where you can have fairly consistent interval between dosing. The only time that you can have the option to change the dose is if you happen to be going out to have a big protein meal. And you know from past experience that you're going to be stuck at the table for an hour. In that case, I would recommend you have the option to take an extra 2,500 Sinemet before you start eating. Or consider using a rescue drug right after you eat, but then they make you nauseous. So I think those are things where you have some options to do things to freelance a bit. How do I really know if the current dosage I've been taking for the past 2 years is too much or too little? Well, that's something you have to talk with your doctor about. Tell them what's going on. I can't tell you from what you tell me whether you're taking too much or not enough. You have just the right amount if you're on all day and you have no dyskinesia. That's all I can say. If you're functioning well on the dosage of medicines they gave you, then you're fine. But if you're wearing off between doses, you're not taking enough. You have to change the schedule. Or if you're having peak dose dyskinesia, you might need to take smaller dose, shorter intervals. Those are things that your neurologist has to discuss with you. You have to show the diary of your reaction to the medication on your scheduled medication to your doctor.
Can I ask a question?
Yeah.
It's Gene Ginsburg. I walked in just a little late, but did you mention the use of amantadine?
Yes.
Okay.
Amantadine is what I would use in individuals who do not yet need levodopa carbidopa, and we want to delay it, so we'll use amantadine early on. And it's good. I'm glad you brought it up because another use for amantadine that's been shown more recently. Amantadine has been around a long time. It's an anti-flu drug used in the 60s, but we're using it when people start getting dyskinesias. So if you take amantadine 3 times a day, usually attenuates dyskinesia. So that's another approach to dealing with dyskinesias besides lowering the amount of Sinemet, increasing dopamine agonists, and using amantadine.
That's how I got on it, because I was having increased dyskinesias and I was having less on time and more off time. And 2 doses of amantadine a day has helped both.
Yeah, it's very helpful. Although, one of the things that I always say about this session, it should not be for a one-on-one consultation, but questions that apply to the general issue of motor complications, even if it comes from you personally, it's okay because everyone will learn from it. But
Right.
private consultation, it takes more than just a simple question.
Of course. One other question. I thought I heard a little bit about this a number of months ago, but have you heard anything about people with Parkinson's who are chronically on amantadine being less at risk of getting COVID-19?
I don't really know that. I really don't know. There's all kinds of rumors. But one thing I knew amongst my colleagues is that during the flu season, I've tried it once, and I'll tell you what my reaction was. If there's a lot of flu around, if you take amantadine like every day, 100 milligrams twice a day, you can protect against developing the flu. Now, I have a colleague who's a psychiatrist in California. He swears by it. So I tried it one year. This is many years ago. There was a lot of flu. I got a sore throat. I said, oh no, I'm just getting the flu. So I began taking the amantadine. Within 3 days, I had a big rash throughout my whole body. And I realized that I'm one of the few people that is allergic to amantadine. So most common side effect, by the way, is a redness in the lower extremities called livedo reticularis, which is not dangerous. But I was concerned when you get a big rash like that, it's not a good sign. So I can never use amantadine now because I know I'm allergic to it. This is what happens, but I'd rather have learned about it then as an prophylactic against the flu. I know very few people who use it as a prophylactic against the flu, but I would rather have all of my patients get the COVID vaccination. That's the best way to protect against COVID, rather than assume that the amantadine is not going to touch you. People with PD are at big risk of complications because it's hard to clear secretion. Whenever you get a cold and you have PD, things are more difficult. It's hard to clear secretions. You already have problems with secretions and swallowing. So it's best to be vaccinated. I think I've got to run now.
I had a question.
You have a question? This will be the last.
Thanks, doctor, for coming and sharing your knowledge. I missed going on cruises with you. But
thank you very much, doctor.
Botox for curling toes. Would you recommend that?
Actually, that's another thing. I had another few items, but I rarely do that. I don't personally inject Botox, but I have 2 colleagues that do for focal dystonia. And it works beautifully. If your dystonia that's related, that's associated with wearing off of levodopa carbidopa is very localized to some muscles in the foot, that works beautifully. And the nice thing is you just have to repeat it every 3 months rather than taking a drug every day.
Okay.
So that yes, Botox, it's good for some people get a cervical dystonia. In fact, Botox is the drug of choice for torticollis, cervical dystonia. But dystonia of the fingers, hands, or feet, if a good neurophysiologist will see which muscles are contracting and inject those muscles, and you can prevent the dystonia in that limb. So yeah, if you're fortunate enough to have an isolated dystonia, that's easily treated with Botox.
It's my toes curl.
Yeah. So that's a good treatment for that, Botox. Okay. Thanks for bringing it up because I didn't mention it.
Thank you for coming again.
All right, then I'm going
Thank you so much, doctor.
Bye, everyone. Stay well.
Thank you.
Stay healthy.
You too. And this is almost over, I hope.
Right. Exactly.
You must be going nuts.
Well, I'm fortunate in that we've been healthy. All my kids and grown-up kids, everyone's fine. So but I've seen too many of my friends. One of my colleagues husbands developed really bad COVID.
That's terrible.
And lost his lungs. He had such severe, he was in the ICU forever, and went to Gainesville, was in line to get a lung transplant. Unfortunately, he got his lung transplant, and he seems to be doing well. But
Oh,
it
good.
can be pretty bad when when it gets the primarily pulmonary disease. And we're people with PD are at greater risk of that. So please get vaccinated and be careful.
Okay.
Mask up in tight places.